Okay, well, good morning. My name is Dr. Stormy Monks, and I'd like to welcome you today to the Grand Rounds presentation posted by the Southwest Center for Pediatric Environmental Health. The Southwest Center for Pediatric Environmental Health is one of 10 PACUs in the United States, which are Pediatric Environmental Health Specialty Units. The purpose of the PACU program is to serve as a leading national source of medical information and consultative advice on environmental conditions that influence human health throughout reproduction and pediatric development. To serve as part of our mission, we offer this Grand Round series once a month on the third Thursday of the month. We are grateful today to have Dr. Filip speak on invasive weeds, a look at the epidemic of pediatric THC edible poisons. Before we invite him to begin, I just want to go over a few housekeeping items. You will not be able to unmute yourself during this presentation. So if you have any comments, questions, or any other type of concerns, please put them in the chat. Someone will be monitoring that throughout the presentation. And then at the end, we'll go ahead and let Dr. Filip know the questions that have been added into the chat. I want to make sure that we acknowledge our funders, the U.S. Environmental Protection Agency, the Agency for Toxic Substances and Disease Registry of the CDC, and the American Academy of Pediatrics. Without these three organizations, the work of the PACU would not exist. If you will be looking for CME or CNE credit hours, I invite you to use the QR code here. This will give you the evaluation that you need to complete in order to obtain those hours. In addition, we will put that information into the chat during the presentation, just in case you didn't have enough time to use this QR code. We also have this QR code that you can use for activity check-in. If you are going into this CME credit program, you can also use the activity code of 3800, and that will be able to lead you to the right presentation for the correct CNE credits. I want to let you know about our next Grand Rounds. It will be on Thursday, September 19th. We will be having an update on PFAS guidance by Dr. Chris Wyant. Dr. Chris Wyant served on the National Academies of Science and Engineering Medicine Committee on the guidance on PFAS testing and health outcomes. Please use the QR code to the side to register for our Grand Rounds series. I also want to make you all aware of some trainings that we are conducting currently. These are our flipbook-based curriculums that are used for those that are working directly in the community. We have currently a training on pesticide use, as well as childhood cancer and its relationship to environmental exposures. So if you're interested in either of those two trainings, we will put our email addresses into the chat and you can email us at a later time. So without further ado, I'm pleased to be joined today by Dr. Filip. Dr. Filip is a medical director of the Arkansas Poison and Drug Information Center, and he is an assistant professor in the University of Arkansas for Medical Sciences College of Pharmacy. In addition to this role, he works clinically on the pharmacology and toxicology consult service for the Arkansas Children's Hospital, as well as the University of Arkansas for Medical Sciences Medical Toxicology Consult Service. He continues to work as an emergency medicine physician at several clinical sites, and his primary interests are in drugs of abuse, medication safety, and care of poisoned pediatric patients. He feels passionately about educating healthcare providers on various toxicology, topics, and is eager to provide opinions on all things toxicology. So we're very fortunate to have him here with us today at the Southwest Center for Pediatric Environmental Health, and we would like to offer him a warm welcome. Thank you so much, Dr. Filip.
Thanks. Appreciate you having me. I'll make sure I've got my screen up. All right, you can see me okay? All right. So thanks for that kind introduction. My name is Filip, and yeah, I work here as a toxicologist in Arkansas, and I work as an ER doctor as well. And so I want to talk to you about what I see as a huge and constantly evolving threat towards our pediatric patients, and that is edible cannabinoid exposures. So just as a bit of a caveat, I'm going to leave a fair bit of time at the end, and I really encourage you all to ask questions and share your experience with this, because this is a phenomenon that we see that's constantly evolving, and I want you to know that there will be some time to chat at the end. I have nothing relevant to disclose, and so today we're going to orient ourselves to the extremely diverse class of compounds that we call cannabinoids. We'll talk about how this might present with acute toxicity in our pediatric patients. We'll talk about some interesting legal loopholes that have fostered this environment, and we will discuss an approach to these poisonings, not so much in the acute sense. I think that's something that a lot of the clinicians will be well experienced with, but more in the population sense. What's next for these poisonings, and how do we approach this from a legal and state and federal perspective. So first, I'm going to walk you through what I see as a regular day for me here on the pharmacology and toxicology service over Arkansas Children's Hospital. And this is something that I'll see probably, if I'm lucky, only once per week, but potentially several times per week. So imagine that you have somewhere out in Arkansas, in rural Arkansas, you have I see a hand raised.
I'm so sorry, Dr. Filip. We're not seeing your slides right now. If you could share, try to share again.
Sure.
Thank you so much. We can see them now. I'm sorry for the interruption.
Okay, sorry about that. All right. Well, I can promise you did not miss anything of anything very colorful of much importance. Here's my pretty slide of Arkansas Children's Hospital. And so so put yourself in my shoes. Imagine that somewhere out in Arkansas while you're on service, there's a 2-year-old patient, and that's crawling around on the ground, maybe putting anything it could in its mouth, as 2-year-olds will do. Maybe comes across some cool looking candy or crackers, and parents notice later in the day that the kid is not acting quite right, that it's a little bit more lethargic, not standing up, and it's pretty sleepy. They use the term wobbly a lot. The kid's kind of wobbling around, not standing up straight. Might be crying or irritable, and so they decide to bring them to their closest ER, which might be half an hour away, 45 minutes away. And then by the time the kid gets to the ER, the child does not look well. The vital signs are normal. The patient is maybe a little tachycardic, maybe a little bradycardic, but is barely waking up, will groan to painful stimulation maybe. In typical fashion, we have given several doses of naloxone out of concern for opioid overdose, and the child does not respond, but fortunately is not hypoxic, and again, the vital signs look normal. They decide to get an EKG, which looks good. They get a bunch of blood work, which looks just fine. And then say this call is coming in from one of our small critical access hospitals. We're a mostly rural state, and they have a child who's barely responding to them. What they're going to do is they're going to contact our major tertiary care referral center for pediatric patients, and they're going to get flown to the mothership at tremendous expense and potentially risk. And when they arrive, if they haven't done it already, there's a good chance they're going to do a CT scan to make sure that the child doesn't have a brain bleed or some trauma, which will turn out to be normal. They might do an EEG to look and see, is the patient having subclinical seizures? Was there an anoxic event? And the EEG turns out to be normal. maybe this is some sort of encephalitis or Guillain-Barré syndrome, something weird, and maybe they do a lumbar puncture, which again turns out to be normal. And so the child ultimately goes to the pediatric ICU, sleeps the entire night, and then at some point, say a resident decides to order a drug screen on this child, which you wouldn't expect is necessary on a 2-year-old. You'd hope that they're not exposed to that sort of thing. And the drug screen shows up as positive for cannabinoids. And this is not something that should be in a normal 2-year-old drug screen. We really shouldn't be seeing much of anything there. And it's not as if, many of our patients, if you were to sample someone from off the street, it might show up positive just because they've been exposed to it or, say, use cannabinoids regularly. But this is not something that we would expect in a 2-year-old. And when we see it there, it's usually the culprit. So the patient sleeps through the night, wakes up. I go to see them in the morning, and the patient is looking just fine. And this is kind of where our toxicology journey ends. But a long and frustrating social work journey begins for that family. A Department of Child and Family Services mandatory hotline report is filed. And so I just wanted to give you an insight into a fairly common phenomenon I deal with here in Arkansas. And sadly, we know that in our altered pediatric patients at this point, we're checking drug screens relatively early, because there's been this huge problem of pediatric exposures to edible cannabinoids. And so before we go too much further, I want to make sure that we're all speaking the same language. And so first, I want to define what we're talking about when we say weed, for example. And so if you're a total square like me, this may be a bit of an education as it was for me. So the broadest term that we'll use here is cannabis. And when you hear someone talking about cannabis, cannabis is just the plant, it's the genus of the plant. There are several types which have varying amounts of THC in them. And so here's cannabis sativa as one example. That's the most common one that we see used. There's cannabis indica. And then when we're talking specifically about marijuana, this is the part of the plant or the strain of the plant that is high in THC. So this is what people use for recreational or medicinal purposes. So, and when we're talking about THC, we'll define this a little bit more later. We're talking about delta-9 THC, which is the psychoactive component of the plant. And then finally, when we're talking about hemp, we're going to use the federal definition of hemp. It's there, maybe a few out there, but this is the federal legal definition. And this is cannabis containing less than 0.3% THC, and specifically less than 0.3% delta-9 THC or tetrahydrocannabinol, which is a very important distinction that we will go into later. And so you've heard me use the term cannabinoids. And what I mean when I talk about cannabinoids, this is a pharmacologic term. This just stands for anything that binds to or interacts with the cannabinoid receptor. So just like we have opioids, which is a diverse group of products ranging from natural products like morphine and codeine, which are found in the poppy plant, to synthetic molecules like fentanyl and buprenorphine, which are not found anywhere in nature and look very different. Just like we have opioids, we have cannabinoids. And so these are any molecule, natural or synthetic, that are going to bind to our cannabinoid receptors. And we have these receptors in our brain, or CB1 receptor or CB2 receptor, and these will interact with those receptors. And so again, very, very diverse. Just like opioids, these are structurally diverse. Some of them look very different than others. They are also extremely diverse in their origin and their effect. And so this includes things like our phytocannabinoids. So these are the cannabinoids that you typically think about when we're talking about cannabis or marijuana. These are our THC or tetrahydrocannabinol, all the way on the right, our cannabidiol, which is CBD, commonly abbreviated. And then there are other phytocannabinoids, which are in there, cannabidiol. And so these are our naturally occurring plant-based phytocannabinoids, we call them. And then we have our things that look like our phytocannabinoids, but they do not come from plants. They are synthetically made. So one example of those being dronabinol or marinol, which is used as an appetite stimulant for patients with cancer, for example. And so this actually essentially is THC. It's a more enantiomer version of THC, but it's made synthetically, and you're not going to find just pure dronabinol hanging out in a plant. And there are several other of these where, for the organic chemistry fans in the room, if we look at their structures, they look fairly similar. They have fairly similar motifs. And then there are other things that are technically cannabinoids, but they look nothing like our phytocannabinoids at all. So here we have our, what we commonly think of our synthetic cannabinoids, but I should say our synthetic indole and indazole cannabinoids, because we see some synthetic cannabinoids that look like our phytocannabinoids. Now these, if we were to again look at their structures, they look nothing like these previous sets of molecules. And they have sometimes these interesting names like Fubinaca, Chiminaka, Pinaka. There are huge libraries of these. And these are the molecules that we commonly think of when they're really popular back in the late 2010s. When I was a resident in emergency medicine, you might have heard them called things like Spice or K2. They were commonly advertised for legal reasons as things like plant food or fertilizer. And so while these are technically cannabinoids in that they will interact with our CB1 and CB2 receptor, clinically, these do not have effects like you would expect marijuana or THC. These can cause agitation and dysphoria. Unfortunately, we don't see these as frequently anymore. And we have made specific drugs illegal, though there are huge libraries and analogs that do keep popping up. These fortunately are not as big of a problem. And when you see that picture over there, if in case you're wondering when, well, we said this isn't natural, well, why am I seeing it just like I would, patch of like marijuana? Well, what they typically do is they'll take some kind of dried plant debris and they'll just spray this stuff right on there. And then finally, we have our endocannabinoids. And so these are our cannabinoids. Again, these look very structurally different that we make in our body. These are natural signaling molecules that will interact with our CB1 and CB2 receptor. And I just want to tell you that this is, not an extremely well understood part of human physiology. We see that it can cause a variety of different effects. It affects cognition. It can affect mood, appetite. And there's some arguments made that it can affect things like inflammation. And so these are a lot of the basic science arguments that often get used in the justification for the medicinal use of CBD and THC and other cannabis products. And so finally, our main concern here is going to be THC. And so I'm going to define some of these chemical terms for you. So when we're talking about THC, this is tetrahydrocannabinol. The long name is delta trans delta 9 tetrahydrocannabinol, but you'll hear me refer to it as just delta 9 THC. And sometimes you may hear me just call it delta 9 because there's other THCs out there. And this is the psychoactive component of cannabis. This is what causes the, euphoria and, potentially the lethargy and other effects. And if you're wondering why we call it delta 9, it for the chemistry fans, this has to do with the 9 position of this double bond right here, whereas the 8 position is over there. We'll get to it later. And when we think about what pure THC is, it's kind of like this liquid or resin, almost called an amorphous solid, and it's extremely viscous. And in fact, people will use products to mimic the appearance of THC. So, for example, when we had the big epidemic of people who had vaporizer-induced pulmonary injury, we suspect that a big reason for that is the use of an additive called vitamin E acetate that people had added into vaporizer pods to mimic the viscosity of THC. And so THC kind of viscous, and so you might see it described in very more pure or highly potent forms as things like wax or dab. When we talk about cannabidiol or CBD, this is something that looks almost identical to THC. So here's a picture of CBD to the left, THC to the right. This is something that's also in cannabis, and I should say more specifically, this is going to be also more prevalent in hemp, which is going to be the thrust of using a hemp product. Previously was the thought that it had CBD in it. This is not psychoactive, or it should not be appreciably psychoactive. It potentially has other effects. It can interact with our cannabinoid signaling system, and this is why people have made arguments for the use of CBD, but this should not cause the same sedating effects as THC, which is why you'll notice that in the legal definition of hemp, they discuss the percentage of delta-9 THC that's allowed, but not the amount of CBD that's allowed. Interesting fact that CBD, if you look very closely, it looks almost exactly like THC. It's just if you took this little ether over here and you just opened it up, there you have CBD, exact same molecular weight. And so THC has been used over time, and marijuana has been used over time for a variety of medicinal purposes. And this is one of the ways that it's made its way towards the general population. There is reasonably good evidence that it works for about 2/3 of people to reduce, to some small extent, intraocular pressure for individuals that have glaucoma. There is some evidence that it may help with chronic pain, even though the effects tend to be fairly small. Looking at large data sets, it seems to be that there is a reproducible small to very small benefit over placebo, which in a climate where we're trying to spare opioid use, people have made an argument that there's a benefit for using this in chronic pain. There are other places where there is not as much evidence, but we've seen it kind of sneak into use. So Alzheimer's disease, for which the major Alzheimer's disease organizations do not endorse the use of THC products as a disease-modifying drug. There's fairly limited evidence outside of basic science research, but this is one of the places that people discuss a potential benefit. Fibromyalgia, if you think of it kind of as an extension of potentially chronic pain syndrome, there's some limited evidence that works, not great high quality evidence. And then there's some other places in the literature where we worry that it has crept in because of benefit, but may actually be doing some harm. So one place we see is it potentially shows some benefit in the acute management of nausea, but as anyone who works in an ER may have seen, can also induce a condition called cannabinoid hyperemesis, which is a very common reason for emergency department presentation. So there's a variety of evidence out there about the potential benefits of medical marijuana, some of it better than others, and some of it may be even conflicting. But a lot of this has been absorbed into our legal framework. And so I'm going to zoom in on Arkansas here. So severe nausea, for example, where we see multiple people who have diagnoses of cannabinoid hyperemesis who wind up prescribed THC products. This is just one of the many conditions that would qualify you here in Arkansas to have a medical marijuana card. So our Arkansas Medical Marijuana Board has determined that things such as glaucoma can be a reason, or certain pain conditions, cancer, but other things like Alzheimer's disease, for example, or arthritis, muscle spasms, can all justify a medical marijuana card. And so irrespective of your thoughts on the matter, this is out there, and there are a lot of medical marijuana cards in states that allow them, in states that have medical marijuana legislation. So to give you an example, here in Arkansas, there's one county, Stone County in Arkansas, rural county, has a little over 12,000 people. And about 7% of the population there has an active medical marijuana card. So that amount to around 870 or so people. There's one dispensary in that county, and that county sold over 100 pounds of marijuana recently in 1 month. So over 1,000 pounds per year. So we got around 875 people with cards, 1,000 pounds per year. A lot of this stuff is making it, it's a over a pound per person in the county. Now, of course, I'm sure there are plenty of people coming from surrounding counties that are making their way there, but 1 in 14 of every man, woman, and child with one of these cards. Suffice it to say that this is out there, and this is very, very accessible. And it's doesn't go unnoticed that, for example, DWI rates in that county have gone up about 40% since 2019. So in terms of the effects that we'll see from THC specifically, and when it's used therapeutically or recreationally, I should say, people might have euphoria. They'll feel good, or they'll describe themselves as feeling high. They may have some impaired judgment. Reaction times can certainly be delayed and can certainly impair vehicle driving. It can cause people to feel more lethargic or sedated. But we're talking here about young kids. And when we think about a kid, they're going to have a size that might be in a 2-year-old and 3-year-old, which are the population of patients that most commonly get into this because they'll pick up anything and put it in their mouth. So when we think about a kid that might be, 1/5 the size of an adult, they might be getting 5 times the dose. And when we think of these cannabinoid edibles, you have a kid, they're not eating just one. You find me a kid who's going to find a bag of gummy bears and eat just one. I've got to meet that kid. But you've got small children. They might be 1/5 the size of an adult. And then here they are eating, 5 or 10 or 20 candies. So they might be getting a dose that is 10s or 20 or 100 times as big as what an adult would get. And in those cases, you can get severe cannabinoid intoxication and poisoning. And so these kids can have significant sedation. They can have impairment to having ordered respirations. Cyanosis is sometimes reported. They can have more typically tachycardia, but can also have bradycardia, especially in small children. Seizure has been reported. So there's a big registry among bedside medical toxicology consult programs that looks at patients that have been seen at the bedside, and pediatric patients specifically, less than 10 years of age, who have had been exposed to these, have been diagnosed with cannabis intoxication. And in these patients, there are a large number of those that are admitted to the ICU. If we look in that middle column, those with a severe clinical outcome. And these patients wind up quite sick, and it's very common that this is the disposition of these patients who will ingest several of these. They might wind up with a low Glasgow-Coma scale, so very somnolent. They are, in a non-trivial number of cases, wind up intubated. So here we see within that subpopulation, about 20% of them. Again, we're dealing with relatively small numbers here, or might need to be mask ventilated. So these are potentially critically ill children, or at least in the view of the clinician taking care of them, the person in front of them had, should they not know that this is, I'm loath to say, just THC intoxication, a kid that appears very ill and needs immediate intervention. And so, within this group, we also saw seizure. There's a case of ARDS, and there was one death, which it didn't go into much more detail on the fatality case. But suffice it to say, these kids can get pretty sick. So we've talked a little bit about the terminology. We know what THC and marijuana and cannabinoids are. We've talked a little bit about the clinical effects and the potential therapeutic effects. But let's talk a little bit about the legal developments that have been happening in the background, because this is really a story in many places in the country, and Arkansas is one of them, where it's really a story of two big legal developments. So first is going to be this 2018 hemp farm bill, or some people just call it the Farm Bill. The formal name is the Agriculture Improvement Act of 2018. And what this does is it codified, among many, many other things, this is just a very small portion of this bill, and certainly not the thrust of the bill. But among the many things that it did is it codified the definition of hemp, and it defined it very liberally as cannabis that has less than 0.3% Delta 9 THC. And we'll go back to this definition in a little bit. But it's basically, if you've got a cannabis plant, less than 0.3% of specifically the Delta 9, it is hemp and it is legal. And so it is not just decriminalized, but hemp and hemp products are legal. And then at the same time, we see in the background of this hemp farm bill, there's separately, and various states have this, there has been a thrust towards legalizing medical marijuana. So we're going to briefly zoom in on my home state of Arkansas. So they had a meandering trend towards legalization here, or I should say legalization of medical marijuana. In 2012, there was an attempt that failed, this Arkansas Medical Cannabis Act. In 2016, there were two competing ballot measures. One of them was struck down by the Supreme Court. But one of them narrowly passed in 2016, and it took about 3 years for them to finally get everything together. And the first dispensary opened in Hot Springs, Arkansas, right as I was, finishing residency, and in 2019. And at the time, people thought, wow, this medical marijuana, I have the feeling that this is really going to take off. They thought that by the current year, 2024, there'd be $47 million a year of medical cannabis sales. By 2023, which is our last full year of data, that there'd be maybe 36 million. That between now and then there'd maybe be close to $100 million in sales. Well, we're way off, and suffice it to say that business is booming, and that there's an insatiable appetite here in Arkansas for medical marijuana. As we mentioned before, I shouldn't say everyone, but a lot of people have these cards now. And so when we think about Arkansas having 3 million people, this is close to about $100 million when we think of Arkansas having about 3 million people, this is about $100 per every man, woman, and child here in Arkansas in medical marijuana sales. And when we think about the fact that there are around 100,000 people in Arkansas that have medical marijuana cards, if my math is right here, this is around $3,000 per card holder. And so I can't, honestly testify with what is happening with all of this marijuana. Maybe that's a normal amount for someone to use, but there's clearly a ton of this that is out there in our environment and out in the community. And the legal climate is varied across our region. In some places like New Mexico, it is recreationally available, and whereas in other places like in Arkansas, medical marijuana only is legal. Other places, low THC medical marijuana is legal. Some places it is decriminalized. And so this varies state to state, but just be aware that there are these two evolving phenomena in the background. There's the federal law, which kind of liberalized the definition of hemp and legal hemp products. And then we have the explosion of medical marijuana industry here in the region. And so let's go back and zero in on this hemp farm bill a little bit more. And so talking about anything is considered hemp when the Delta 9 concentration is not more than 0.3% per dry weight. But one of the important things is that it also makes a mention here that any part of the plant, including any derivatives or isomers, is also legal within that plant. And so this is where many of you may have heard of this. Products like Delta 8 THC have made their way into the scene. So Delta 8 specifically is, or Delta 8 THC is THC, similar to Delta 9 THC. It's just a change in that position of that bond. So instead of at the 9 position, it's at the 8 position. And this is psychoactive THC. This is, some people say about 50% is potent. Some studies say about 60% is potent as Delta 9 THC. And for any toxicologists, the saying goes, the dose makes the poison. So if you're taking a 30 times dose of something, it may be a little less potent, but it's going to be a lot worse than if you're taking a 1 times dose of something that is of normal potency. And so this, by virtue of that farm bill, is legal from a federal and state standpoint, because this is not Delta 9 THC. And the way that they make this is that they derive it from CBD, which is within the plants. And now this, I want to say, I really do think of this as a legal loophole, and I hope I'm not getting myself into trouble here, because there is no plant that naturally produces delta 8 THC. I mean, it does produce it in trivial quantities, but it is not producing 10, 20, 30% delta 8. What is happening is that they're extracting and using CBD, and they are, by various chemical processes, turning it into this delta 8 THC. And because it's not delta 9, it doesn't really matter how much of it is in there. And not only are these aren't sold at dispensaries. What happens is that there's no regulation on these. They are sold at gas stations. They're sold at various head shops. And so here's some examples of products that have found out, made their way into the market. Our medical cannabis industry here, they adhere to the 1970 Poison Prevention Packaging Act regulations. Their packaging cannot be made attractive to children. There is a pharmacist that is on staff for these dispensaries, whereas these Delta 8 products, it is the absolute Wild West out there. And these products, they really look often like candy. They're not highly regulated. And so, it goes without saying that if a kid comes across this and there's an open bag of this, they absolutely might wind up trying to eat some of this. And so what we have here is kind of the perfect storm. We have an area, and this is going on in many states, where marijuana products become increasingly prevalent, normalized, increasingly available by virtue of the expanding medical marijuana industry. And then we also have an influx of these unregulated, deceptively packaged products, these Delta 8 products. And in the middle of this is a bunch of pediatric patients who all they see is something that looks like candy. And so this winds up being, again, kind of the perfect storm for what we're seeing. And how is this presenting from an epidemiologic basis in our state? Well, we started collecting data from a poison center standpoint in around 2018 on marijuana edible exposures specifically. And some of this may just be because we weren't yet tuned into how to code these in our call logging software, the Poison Center. But we see maybe, we'd have a few cases per year for the first few years, and then it has just absolutely taken off. It has risen in exponential terms in each of the past 3 years, and we're currently on trend. The trend seems to be holding up, I'll say. And this is, again, specifically the edible preparations that I'm going to identify as the culprit. It's not as if a bunch of 2- and 3-year-olds are coming across, lit marijuana cigarettes or eating a bunch of, dried plants, of which that is, some component of this, but it is primarily these edible preparations that have been skyrocketing. And so what does this do to kids? Well, I've talked with you about a lot of evidence and numbers, but I just want to kind of share some anecdotes, with some de-identified anecdotes of things that have been going on in our state to really help you understand the gravity of the situation. So there is, for example, a case of some students who referred to our emergency department after sharing a edible marijuana preparation that was later confirmed to be Delta 8 THC. Multiple children wound up in the hospital to be evaluated. That's also going to wind up being, multiple reports to social work. We have a case where we have a total of at least 3 cases from recent memory and discussion with colleagues of individuals who have been transported by helicopter to Arkansas Children's Hospital. And at expense of each of these transfers, easily in excess of $20,000, who were later determined to have ingested edible marijuana preparations. There are multiple patients aged 2 years and younger who have had seizures or required access or required, admission to our pediatric intensive care unit. And so, adding up the past 3 years of individuals who have had a final diagnosis of accidental cannabis poisoning, because not all of these ingestions wind up at our children's hospital, but many of them do. Over the past 3 years, we've seen over 100 of these cases. And so it's not just the immediate costs, the in-hospital costs that we really need to worry about here, which some of these costs, again, can be astronomical. There's costs of send out testing associated with this, but there's send out testing, there's all the workup that happens in the hospital, not just their ICU stay, but their blood work, their imaging, the unnecessary radiation. But there's tremendous costs from a social work standpoint, monitoring, following up with families. And this is not necessarily just a financial cost. This is a significant burden on our already overburdened state resources. It soaks up their personnel to have to respond to all of these cases, and our DCFS is responsible for keeping our kids safe, and they're being stretched thin by this. And there's finally this intangible cost to families. Some might feel ashamed of the fact that their kid got into their edibles. There may be a loss of trust from family members in the healthcare system. That they brought their kid to the hospital in good faith, and now there's a report opened up against them. There may be situations, unfortunately, where where the system feels that it is that this is the straw that breaks the camel's back, and that the children wind up not in remaining in custody of their family, at least for a short period of time. And so you may be wondering, well, is this just people need to do a better job of locking up their Delta 9 THC medical marijuana prescription marijuana? Well, we're seeing that a large part of this is likely driven by Delta 8's concurrent rise. And so this has largely flown under the radar, because the unfortunate thing is that there's no way to know from a regular drug screen whether or not it is Delta 8 THC or Delta 9 THC. They are just going to show up as cannabinoids. And the hard thing is, even if you do one of these complex toxicology screens that you send out to a lab that looks for all the different things that kid could have gotten into, and it uses a GC mass spec to identify the exact compound, it's still just going to show up there as THC. You actually have to spend a very specific lab that looks to be able to separate the two isomers of them. And it's not only until recently that we started routinely doing this on some of our pediatric patients, so that we can really try to identify the burden of disease here in Arkansas that these Delta 8 gummies have taken out on us. So there is some action that people have taken to try to mitigate this. There was a law here in Arkansas that was passed to try to ban isomers like Delta 8, Delta 10. It is one of the few things in Arkansas that has absolutely unified both political parties. It was passed by the Arkansas State Senate heartwarmingly 30-1. And yet there was a last-minute injunction that it was felt that this violated the hemp farm bill, and that this is unconstitutionally vague, and that we need more time to figure out whether or not we can pass a ban on this. So despite overwhelming bipartisan support within our state, these products still roam free here in Arkansas to this day. We've personally written to our Attorney General, who has in turn written to some of the heads of our committees that are looking at the hemp farm bill. The hemp farm bill was due to reauthorize last year, but is a little bit delayed, and so they're currently marking it up right now. But as for right now, Delta 8 roams free in Arkansas, and there's no real legal regulation of it. And this is not just Arkansas. Similar thing happened in Texas, where the Texas Department of State Health Services tried to ban Delta 8, and there was an injunction. And again, Delta 8 in Texas roams free. In Oklahoma, it seems to be that they have just decided that they're going to say that Delta 8, they have explicitly, under the interesting title of the Medical Marijuana Inpatient Protection Act, it just decided that Delta 8 is not recognized as marijuana, so it's not covered under legal restrictions. So Delta 8 there roams free. So the legal climate varies at different places in the country. Some places have been successful at significantly restricting this or at banning this. In other places, like Arkansas and Texas, it's completely legal. But this does remain a common cause of accidental pediatric poisonings. And so you thought that we were done here. We've got Delta 9 and then we've got Delta 8, and we're trying to figure out a way that we might be able to at least get it under control so that we're not having this explosion of poisonings. But these analogs are kind of popping up faster than we can really even address them. And so this is from a product that one of our patients presented with recently. There are other cannabinoids like THCP that are evolving, tetrahydrocannabinol. And so this just has a long alkyl group at the end of it that makes it more potent. And so, when we look at these products here, we're seeing just astronomical numbers. This is the amount in the entire container, but 15,000 milligrams of THC. And in some cases, there are hundreds of milligrams of Delta 8 THC or of THCP and other analogs. And so, some of these things like this THCP, I don't want to add any undue, hysteria towards this by calling it like the fentanyl of, THC, but the potency is about 30 times that of Delta 9 THC. And so these are things that if not correctly used, or if someone encounters a large amount of this, has the potential to cause very, very significant consequence. And so there's a whole variety of cannabinoids and THC analogs that have sprung up. And we see the base product here is CBD. That's kind of the way they're able to get through this loophole. They use THC as their natural extract, and they derive it into different things like our THCP, our THCO acetate, which is used in a variety of different products. You can see this kind of commercially available. Your THCH, tetrahydrocannabihexol. This again, other products you can just find them and try to order them online. And some of them come with mixes of things like Delta 10 and THCH and THCP, and they're trying to find the right blend. So what can we do about this? So the first thing I want to talk about is increasing exposure to these products, because I'll be honest with you, until about a week ago, I didn't even have THCP on my radar. I didn't even know what it was. And there are more of these that are popping up than I can even keep track of. And so, I work here for the Poison Center. And so if I'm not aware of them, I just wonder, do people know about Delta 8 THC? Do they know about the legal climate that's going on? Because I want people to be aware that these THC edibles can and are causing this, epidemic of poisonings within our state. So I think that we should really do a good job of integrating this into curricula for teaching residents, teaching healthcare professionals, teaching our social workers, because this does really permeate through the entire healthcare and social services system. So people should really be aware of this. So next is going to be educating our parents. So, I have a kind of tongue-in-cheek image down there, but in all seriousness, it's important to make sure that parents are aware of how dangerous this stuff is. However your feelings are about medical marijuana, the dispensaries in Arkansas, they require a pharmacist and compliant packaging. When this is treated like a medication, as if it's going to be out there, it should be a medication and locked. But whether or not you endorse the role for it as a medical or recreational product, you should respect it and recognize that it can cause significant poisoning in young children, and realize that there is danger to kids here. And while I do focus on kids, I just want to say that really everyone here is at risk. I can't tell you the number of mimas that have shown up in the hospital after eating some gummy bears that they thought was just gummy bears from the cabinet, and it would surprise you. So we really need to make parents and family members aware and kind of respect the risks of this. Next intervention will be using medication lockboxes. And so this is something I'll say quite honestly, there isn't a great outcomes data on how well this works, but this is something that I can just say it seems to make sense. Our intuition is that it seems to work. And so if you can give these out, I'd encourage it. And you might think, who's going to go out and buy a lockbox and keep their drugs there? Who's actually going to use these things? Well, they've done studies in this specifically with things like pregnant patients who are storing Suboxone who are storing their Suboxone, and they're given lockboxes. When they follow up on them about 2 months later, around 90% of them are actually using these lockboxes. People might not necessarily be inclined to do so for THC, something that they might see as more benign. But the hope is that if we make them available, people will use them. And then, I hate to embarrass if any of you are watching, or if Dr. Banner happens to be up there, but some of you are really experts in risk communication and navigating complex political systems, and some of the toxicologists and public health officials, our legislators really do rely on you in being able to communicate, what are our genuine risks out there? What are the things that maybe, well, the risk is overblown, or there's a bit of unnecessary hysteria of this? And what are the things where the gravity of this problem really isn't quite felt yet? And you're going to be the canary in the coal mine, being able to make people aware of this phenomenon and communicate risk. And so with the blessing of your institution, of course, I encourage all of you to reach out and speak to your lawmakers in ways that you feel would be reflective of what you think is going to be a good action towards protecting our patients. And then finally, it's going to be, recognizing and treating underlying substance use disorder. It really wasn't until actually our DSM-5 version of the psychiatry manual that we even recognize that the cluster of things that we think of as cannabis-related disorders. So, cannabis use disorder, cannabis withdrawal. And, it's certainly possible that a big role in this and high prevalence of products floating around here is that, it's very available, and the non-trivial number of people do end up developing use disorders for cannabis products. And if this stuff is out there, if people are using a lot of it, then kids are going to get exposed. And the prevalence of use disorder among people who use cannabis is not trivial. About 10% of people who start with smoking marijuana might eventually meet one of these criteria. And around 30% of people who regularly use it might potentially meet one of these criteria. So I don't want to end on too much of a downer. I will say that there is a kind of a ray of hope out there. We mentioned the Farm Bill, which was supposed to be revised in 2023. Well, it's just made its way out of committee, and the most recent iteration of the bill, which still has to go to the House, still has to go to to Congress, states that the THC definition, the definition of hemp relies on the amount of total THC, so not just delta-9 THC, and that hemp only includes non-synthetic and non-intoxicating cannabinoid products. And so there's a lot of language in there that's clearly directed at mitigating the spread of delta-8, of THCP, and all of these other cannabinoids out there. So got some references here. And finally, I just want to open it up to questions, because I suspect that I'm not the only person that's seeing this phenomenon. And I know from looking at the nationwide numbers that we are seeing exponential increases in the number of pediatric edible exposures. But if I am the only person seeing this phenomenon, that's fantastic. And I'd be happy for it to be just a statewide problem. But yeah, if there are any questions in the chat, I'd love to hear them.
Thank you, Dr. Filip. That was fantastic and very informative presentation. We've got a couple of questions that are starting to trickle in here. I suspect quite a few more, but we'll start at the top. First one is, are there any long-term health effects expected for the pediatric patients that are exposed to such large doses at a young age?
I don't think we have good enough long-term data on this, and I'll be honest with you and say that I haven't seen any studies that provide follow-up after these single acute exposures. I would suspect, like most single acute exposures, probably it's not going to cause a durable effect, but I don't have enough evidence to say one way or another. I usually I'll tell you, my counseling to patients is that they're going to be just fine once they recover from this. But I really don't have a great evidence base to say that.
Next one is, are the poison centers educating people about THC poisoning and cannabis use disorder? Asking because many of my patients who have comorbid cannabis use disorder and other SUDs might have zero insight into their cannabis use disorder, even if they recognize the issue they're having with alcohol, opioids, etc. You know, maybe this is keeping with the natural equals safe bias. Just any thoughts there?
Yeah, well, first of all, I'll just say, yeah, I completely, I totally get it. You know, I mean, it's again only recently until they really acknowledge that this is a substance use disorder. Usually the poison centers don't have as much of a role in terms of, you know, I consider this to be within the realm of addiction medicine. And when we get calls, it's usually about acute exposures, acute poisonings. We are, our thrust is more medication safety. So if the medication is out there, if the drug is out there, just making sure that people are safe with it. But in terms of trying to guide people away from use disorders, there's a separate, much larger specialty of, you know, psychiatry and addiction medicine that is really trying hard to do that. But you know, I do think that there may be a role for more collaboration with them in helping to inform their discussion with them and showing them just how risky having these products around may be.
Do you know if these are being specifically marketed towards pregnant women, or have you
That I
seen
know
that?
of, and I really hope not.
Um, and this one could be, I don't mean it to be loaded, but just curious if you have any thoughts on what clinical use public accessibility changes we might see if any of these substances do actually go through the DEA descheduling that's kind of in the works, or do you have any thoughts or willing to say anything?
Yeah, we've had we've had a lot of discussion about this, of what happens when they try to reschedule it. And all I'll say is that you know, I think that it will probably be very, I would encourage clinicians and people who are involved in the sphere to reach out early to their legislators, their state marijuana boards, whoever is kind of uh, whoever's control their state pharmacy boards, I guess would be the more appropriate group, because these are you know, the regulatory decisions, the decisions that relate to toxicity, or the evaluation of, you know, the evaluations that relate to toxicity and exposure risk and harm. These are discussions that you would like to have a clinician in the room, and not kind of lawmakers who might have a different set of priorities. But we don't have a perfect plan yet for what happens, but we're just trying to try to dig our heels in as much as we can, because we would like to be in the room when a lot of these decisions get made.
So a couple of other questions coming in. Do you know how common THCP is now being utilized with other edible products or other formulations? The Torch is the first edible I've seen with this compound.
Yeah, so I'm not aware of other ones. We've had two separate you know, Torch edible ingestions, and we actually emailed the folks at the mothership, the National Poison Data System, to see if they needed to create any additional product codes for the specific subset of these products, or for THCP specifically, because we're really worried that this could be an evolving phenomenon. But that Torch is the only one that I've come across.
Okay. And other questions coming in: is anyone in the country systematically collecting data on the reach of medical marijuana to those individuals beyond card holders to try and quantify use? I realize that would probably be a very difficult study, but you know of anything that might be happening like that?
Yeah, it'd be hard to do on a. That's a good question. I don't know if there is anyone doing this. The climate is so fractured state to state, in that it's usually the state that kind of monitors and gives out medical marijuana cards. So I think that that'd be really challenging. I will say that here in our state, one of our researchers is actually looking at outcomes that will, you know, ED visits within the population of cardholders, And so there are ways that you can try to work with those folks to get what I think is pretty interesting data, but to do that on a national level might be challenging. There's not some like data consortium like there is in certain toxicology circles that does this.
And there's one more of a comment, but feel free to provide your thoughts also about statement that we had the state police come and talk to our agency health department a few years ago. And what surprised me is that one alteration to the chemical structure can allow the manufacturer to claim the drug is legal and sold in any shop.
Yeah, I mean that's pretty much how they're getting through this loophole. Because Delta 8 is it is an alteration to the chemical structure of CBD, which is in hemp. And they're saying that this is a derivative of CBD. And this is not like, they're letting it out in the sun and it turns into CBD, or sorry, turns into Delta 8 THC naturally. This is like very deliberate, lab chemical conversion processes that are happening. And so there is truth to that statement. And similar to how we've seen all this explosion of fentanylogs, and we've seen, libraries of synthetic cannabinoids, we're kind of starting to see, a similar phenomenon with phytocannabinoids, where we kind of have one base structure, which is CBD, and then we're just altering the chemical structure and saying, hey, we're covered by the hemp farm bill. And that seems to be what's happening.
All right, I don't see any other questions, and we are just past the top of the hour. But again, thank you so much for this very interesting, educational, informative talk. Generated quite a few questions and discussion here.
Great. All right. Well, thanks so much. I appreciate you having me.
Thank you.